although this one's, that'll take some time. Okay, we're going to come back into focus here, proceeding with Chair Hernandez's bills, and we'll start, Chairman Hernandez, with item 1, SB 932.
Thank you, Mr. Chair and members. Studies show that entities with high market concentration can command high prices that are way above market rates. Researchers found in our own health benefit exchange that if a hospital concentration were reduced to moderate, concentration levels and overall premiums would be 2% lower, and in 3 counties, 10% lower. With the Affordable Care Act, we are compelling individuals to purchase health insurance. If we don't do everything we can to keep rates low, purchasers will expect government to step in and to regulate rates. This bill is necessary because it takes off the table requirements agreed to under contract coercion that serve only to a limited competition and guarantee payments way above market rates. Purpose of this bill is to create balance and transparency so that the market can function to moderate rates so that government isn't asked to step in. There are 2 parts to this bill. The first part deals with contracting practices that are devised solely for the purpose of insulating an entity from competing in the healthcare market based on quality and cost. These practices force parties into a contract that are not only dictates the prices for the contracted services, but also dictates prices way above market rates for emergency service with non-contractual affiliated entities. The second part of the bill has to do with the healthcare mergers and acquisitions and creates a structure for additional scrutiny on the impacts of mergers in California, healthcare market, and competition. I'd like to request the committee adopt amendments that will narrow and clarify this bill, and these amendments are in the form of a mock-up. If you look at them, they're in front of you. I know there's been some concern with regard to CDI, which I will make some statements. I'm going to hopefully be able to address some of those concerns. At this point, I'm willing to remove that portion of the mock-up and until we clarify whether the legality of it is correct or not. But with that, members, I have some individuals that would like to speak here on behalf of the bill.
Mr. Chair, could I just check with you on, is it your preference that we would do 6 minutes in favor?
Yes, if at all possible, yes.
So you can help me with timekeeping. So again, for the proponents in favor, we're going to try to have a total of about 6 minutes. We'll be flexible, but if you could try to, I know there's some detail on this, but want to be respectful of both sides, and we'll keep track of time to make sure we maintain a balance. So with that, please introduce yourself, witnesses in support.
Thanks. I will try to be brief, both mindful of the time and the time of the afternoon it is. I really respect your the stamina of this committee. It's quite impressive. I'm here to speak in strong support of the competitive healthcare contracting provisions of SB 932. My name is Christoph Stremikis, and I represent the Pacific Business Group on Health, as well as the Silicon Valley Employers Forum. PBGH and SVEF are both nonprofit California-based membership organizations that represent about 65 large employers that are purchasing and providing coverage to millions of Californians in the state. All our members are united in their dedication to improving care and affordability of health care, both here in California and across the U.S. health system. Last year, I was trying to figure this out. They spent about $12 billion on health services here in California, quite a bit of money, and a little more than $45 billion across the U.S. We strongly support efforts by this committee to level the playing field among healthcare providers, plans, purchasers, and patients in California. It's apparent to all of our members that the market as it exists today is not working. It's failing. The problem is particularly apparent in Northern California, where our members and the plan vendors that they work with have no choice but to accept anti-competitive contracting terms that are being dictated to them by a few large provider systems. Many of the provisions of SB 932 that Senator Hernandez mentioned directly address these unfair practices, and we think will lead to lower costs for our members, their employees, and those employees' families. The empirical literature and our collective experience on this point are clear. I won't belabor this point, I'm sure you've heard it before, but healthcare costs more when the provider market is dominated by a few large systems. I don't think any of us can argue that this is not the case today in California, again, particularly in Northern California. Legislative and regulatory intervention like SB 932 are needed when these large dominant systems are using their leverage to impose unfair contracting terms and demanding unjustifiable price increases. This is happening. What are some examples? Our members often try to identify and reward those hospitals that are providing the best outcomes at the lowest cost to patients. In some cases, this is being prohibited by dominant systems who demand that purchasers include either all or none of the facilities within the network, regardless of the performance. All or none isn't a real choice. In many geographies, including none of a dominant provider's facilities, will leave you with exactly none or no choices for beneficiaries. Language in SB 932 explicitly bans these unfair all or nothing clauses. Our members are equally supportive of providing patients with the information they need to become more informed healthcare consumers. Unfortunately, some dominant providers in California are still preventing employers, plans, and other vendors from disclosing the contracted prices of a certain service or procedure before an employee receives care. This obviously undermines efforts to make the healthcare marketplace more responsive to consumers. I could go on and on. I'm happy to submit additional examples for the record. In the interest of time, I'd like to yield the floor to some of the other members that are in support. I would just close by saying both PBGH and SVEF and our members strongly support this bill and urge you to advance it.
Thank you. How much time do we? So there's 2 minutes, 30 seconds. Again, there's a lot of you that have something to say. Please try to be concise.
Good afternoon, Mr. Chair and members. Tam Ma with Health Access California here in strong support of SB 932. We support both provisions in the bill, and I'll focus my brief comments on the health insurer merger piece. Health Access has been engaged in the state's review of the 4 mergers that have been proposed, health insurer mergers that have been proposed in California over the past year. We've asked regulators, both at DMHC and CDI, to impose strong conditions when they can on these mergers to make sure that they're actually in the interest of consumers. We found that the state's process for reviewing these mergers could be strengthened and would benefit from clear criteria that allows consumers to benefit in the form of lower prices, better quality, and improved access to care. Right now, the Department of Managed Healthcare's authority is limited to reviewing consumer protections and financial solvency requirements under the Knox-Keene Act. DMHC does not have the authority to look at how a proposed insurer merger actually affects price and competition in the larger healthcare market. We also appreciate that DMHC has held public meetings over the proposed insurer mergers, but we must note that they are actually not required to hold public meetings in statute. So we believe that this bill will provide the DMHC with effective oversight over health insurer consolidation by providing the clear authority and consistent standards for reviewing these mergers, and understand that the author is proposing to take CDI or not include the Department of Insurance in the bill now, but we'd like to be part of the conversation to review what the legality of those issues, but we'd ideally like both regulators to have the same authority in reviewing these mergers.
Thank you.
Mr. Chair, members, Sarah Flocks from the California Labor Federation. I know time is short, so I would like to echo the comments by the employer group. It's always good to be here on a labor management supporting a bill. We are very much supportive of the prohibition, the ban in this bill on anti-competitive contracting practices between health facilities and health plans. I think the amendments that the senator is proposing clarified that this is not about individual physician contracting. This is dominant health providers that use monopoly power to impose anti-competitive provisions in contracts. I also wanted to just reference that in 2011, the Federal Trade Commission and the Department of Justice came out with recommendations for accountable care organizations. They had a list of 4 which they recommended that ACOs avoid so that they didn't run into antitrust problems, and many of these are included in SB 932. So we would recommend you move this bill forward. Thank you.
We are up against time. I'm going to allow you to share some comments, and then I'm going to consider the health plans maybe to be a little different prospective stakeholder, so we'll afford you a couple of minutes.
I'm going to be quick. Michelle Cabrera with SEIU California on behalf of our 700,000 members statewide. Corporate consolidation does not equate to more integrated care, and we have a long way to go before we deliver on the promise of care coordination. For those reasons, we're in strong support.
Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. I'd like to thank the author. We had good, productive conversations early on about the bill. We did see the amendments this morning that did add CDI into the bill. I think we do have concerns. The Holding Company Act was a nationally recognized NAIC model regarding domiciled insurers. I think we'd like to look at the legality of that and how that would affect if we expand the authority to non-domiciled insurers and how that would interact with the nationally recognized Holding Act. So for those reasons, we requested that we take a moment and look at the legal implications of adding them in and what the best policy would be, and to work with the author and CDI as the bill moves forward. Thank you.
Thank you. Okay, so now any others in support, please?
Linda Way with Western Center on Law and Poverty in support.
Thank you. Mike Montgomery, Congress of California Seniors. We support the bill. Thanks.
Sam Rodriguez on behalf of the United Food and Commercial Workers, Western State Council, in support, and we appreciate the authors and the chairman's efforts to this effort. Long overdue. Thank you, sir.
Beth Capel on behalf of Teamsters and Unite Here in support.
Thank you. Seeing no others in support, I would invite opponents to please come forward and situate yourselves.
I'm not an opponent, I'm
in between. So why don't you lead off? We'll afford you 2 minutes, and then opponents will start with 6 minutes, and we'll be a little flexible on that.
Sure. Janice Rocco, Deputy Commissioner on behalf of the Department of Insurance. Given the ACLIC testimony and the fact that CDI is not being added into the bill today, I just did want to share with the committee a few things. The Holding Company Act, which is in the insurance code, does not have some of the strong protections that you'll be adding to the health and safety code through this bill. So we're asking to have those strong protections added to the insurance code as well. Right now, the Holding Company Act applies to domiciled and commercially domiciled companies. As we're looking at the big mergers right now, Anthem, Cigna, Aetna, Humana, the four that are proposing to merge through 2 different mergers, the Holding Company Act does not apply to merger approval because they're not domiciled or commercially domiciled here. But if you put the provisions into the insurance code that you're putting in the health and safety code through this bill, then we would have that authority. Additionally, there are protections in these health and safety code provisions that do not exist even for domiciled companies in the insurance code right now. And so, we would like to have the same provisions. And our attorneys did look at the Holding Company Act, which they've worked with for decades, and crafted amendments accordingly. So we know that this can be done. And we appreciate the author's efforts, and we'll work with him and ACLIC.
Great, thank you.
And just to clarify that, there is a willingness to look at that because we want to look at the legality of it. It's not to exclude them, but to make sure that it's done appropriately. And just to clarify, there has been, this is a pretty lengthy bill, but we're going to be removing all of the sections in 10133.61, which is all the way to subsection B.
And that's reflected in the mock-up?
Should be reflected in the mock-up, but just
Great.
wanted to clarify.
Thank
We
you.
have the mock-up here in front for everybody. So.
Great.
Mock-up adds it in. You want them to cross it out of their mock-up.
So the mock-up adds it in, and we wanted to cross it off in the mock-up.
Okay. So now we're going to move to opponents. You'll start with a fresh clock of 6 minutes, and again, we'll see where we are in 6 minutes. But if you can try to do a division of labor, that would be appreciated.
Good morning. Good afternoon, everyone. My name is Juan Thomas. I'm representing the California Medical Association. First, just a quick comment about the amendments that we received this morning. We do appreciate the senators' attempt to recognize particularly difficult plight of small and individual practices to try and carve them out the bill, but from our perspective, the amendments do not do that. And it's also important to to understand that CMA, our physician members are in every mode of practice, from small and solo to medium to large to very large groups. Having said that, I'd say CMA has long been concerned with consolidation in the healthcare markets, particularly consolidation amongst the largest for-profit insurance companies. However, SB 932 is the wrong solution that would not only fail to solve any of the problems caused by consolidation, but would have catastrophic consequences for both patients and physicians. The proposed legislation would give health plans and health insurers more power to further restrict access to health care, more influence over physicians' clinical and business practices, and would force physicians to cut costs, resulting in a significant degradation of their ability to provide the quality of care that patients value and need. The bill would prevent physicians from collaborating with each other, other providers, including hospitals, to ensure for-profit insurance companies provide robust networks to patients. For instance, the bill would prohibit physicians from seeking to negotiate a contract with a for-profit insurance company that would require the company to include all the physicians in the insurance company's network. This would allow the insurance company to carve up the network as it wishes, creating skinny networks that further restrict a patient's access to care. Stripping physicians of this ability at a time when they already have little negotiating powers, as the already large insurance companies get larger, would likely decimate provider networks. Another provision in the bill would prohibit physicians from seeking to negotiate a contract with a for-profit insurance company that would place all the physicians in the same tier. I think this is important because we have many folks in that small solo practice, say in OBGYNs who have patients who are pregnant. Someone may need to be backed up. If each of the 5 OBGYNs are in a different tier, this is likely to have a financial impact on the patient if one of the doctors asks the other doctor to cover that patient. Still, another provision in the bill would prohibit physicians from seeking to negotiate a contract with a for-profit insurance company, a contract that would ensure that the physician has access to all patients who are members of that particular plan. In a preferred provider network, there oftentimes are providers with different levels of reimbursement. When you sign a contract taking lower rates with the notion that you're going to be promoted equally, or have some assurances that the insurance company won't funnel patients around you who may be getting a little higher reimbursement rate than the lowest one. This would prevent a provider or physician from seeking a clause that would give you some assurance that you would get equal billing when it comes to promoting you to the enrollees and the members of that plan. This bill also has a provision that sets rates for physicians who do not have a contractual relationship with the for-profit insurance company if they've provided emergent care for one of the company's enrollees. Quite frankly, this is one of the more confusing clauses to us. We don't quite understand what it's trying to do. Also, the bill contains language that makes void and unenforceable any contract that contains one or more of the prohibited contract provisions. This would require plans to issue new contracts to all providers, and in the process exposing physicians to less favorable contracting terms with virtually no time to comply with the bill's provision. This will create massive disruption in the provider networks, which would further disrupt and delay patient care. Commercial networks are narrow and getting more constrained today. A study by the University of Pennsylvania researchers shows that 76% of the health plans in California sold in California through Covered California have significantly limited networks. This bill does not reduce healthcare costs for patients, but rather result in higher profits for insurers at worst, and at best authorize for-profit insurance companies to not meet their obligation to ensure their customers have timely access to quality care. SB 932, while preventing physicians who've merged or affiliated from gaining the benefits of collective action, fails to ensure that for-profit insurance companies fulfill the promise to use their increased market power to negotiate lower reimbursement rates from providers and translate that into lower premiums or lower deductibles for patients. Instead, at CMA, we're confident that these for-profit insurance companies will use the provisions of this bill to further increase their market power, which has consistently resulted in limited patient choice of physicians in the form of narrow networks without sufficient physicians, reduced administrative capacity and resources to ensure quality health care access to patients, and the loss of incentives for health plans to collaborate with physicians and providers to provide innovative care. So in conclusion, the 41,000 physician members of the California Medical Association respectfully urge a no vote on SB 9.
We can just
Well, you've
hold
just-
the time for a little bit. I'll
Yes.
just respond very quickly. I know, how much time is left for the
No,
room?
he's used the 6 minutes. So you came right in on the 6 minutes. I want to congratulate you, but you've precluded the other opponents. What we'll do, Mr. Chair, is it your preference to respond
I just
now? And then we will afford you some time, but it's going to be a couple of minutes more out of fairness. The opponents were held to just over 6 minutes. You've used your 6 minutes. This is complex. I would invite the submission of written testimony and in the future, it's good to plan ahead, divide up, talk about what you can, and do the rest through written submission. Thank you. Mr. Chair.
So, Mr. Chair and members, understanding the complexity of this issue, I've tried to address as many of the concerns, and I think if you look at a lot of the strikeouts from Section 1399, it does address it. I realize that there was some last-minute amendments in the mock-up. Perhaps they didn't get to take a complete look at it. And with regard to the tiering, it specifically says within the amendments that you cannot tier individuals. So there's not any evidence to that whatsoever. What I would suggest is perhaps if you do give more time to the opposition, that you allow the support to come up and maybe add to it, because, it's a very complicated bill. So maybe if you can allow the opposition a few more minutes, and then as well, equal amount of time to support.
Yeah, I think that's fair. So what we'll do, there's the two of you, we'd ask you to be concise. We're going to keep track of your time, and we're going to offer that time to the proponents.
Thank you, Senator. And of the 6 minutes, how much do we have remaining?
There's none.
None.
So you're starting de novo, and the minutes you use will be offered to the proponents.
Thank you. Mr. Chair, members of the committee, Alex Hawthorne on behalf of the California Hospital Association, thank you for your consideration and allowing us to speak a little bit longer. I will be brief. We reviewed the amendments this morning. We're still reviewing them. At this time, we do remain opposed. I'd like to open by saying that we have a very diverse membership like CMA. We have hospitals of all sizes that serve rural and urban areas of the state of California, and we're very proud of the contributions that we've made in implementing the Affordable Care Act and achieving the goals of the Triple Aim. The diversity of the state that we live in and CHA's membership demands innovation and collaboration between hospitals and other entities in healthcare. And we have to do this to best serve the needs of individual communities in a very diverse state. One of the most critical tools that we have at our disposal to do this is to enter into partnerships. And the provisions in this bill would limit our ability to do this, and by extension, it would interfere with our ability to innovate, collaborate, and integrate care to best serve patients. Sort of counter to what was brought up earlier, increased collaboration, integration amongst providers is reducing healthcare costs. Over the past 3 decades, the hospital's share of costs in healthcare has diminished, and California's per capita healthcare costs are lower than the national average. The healthcare market has changed dramatically since the implementation of the Affordable Care Act and will continue to change in the coming years and decades. So we believe that making the broad sweeping changes called for in this bill would cause a massive disruption in the marketplace and have unintended consequences for providers, payers, and patients. And with that, I would respectfully request a no vote.
Thank you.
Thank you, Senators. I'll be very brief. David Gonzalez here on behalf of CAPG. Our providers operate in some 210 physician groups throughout the country and are responsible for the care of some 20 million patients. We're still reviewing the amendments. They're pretty extensive. And at first blush, I'd like to first thank the author for removing the reference to the risk-based organizations. That was a big improvement for us. So I want to thank the author and the staff for working with us on that level. So we're very happy for those amendments. But while we're still reviewing the amendments, we still remain opposed to this premise that the provider groups are a problem in terms of the consolidation that's going on in the market. Just last year, 40 new groups were formed, so it's a very competitive market. And over the last few years, our contract rates have been at the flat to 2%. So we're not a cost driver. So in light of all these consolidations that are happening in the market, I know there's concerns about the insurance market, but on the provider side, as far as the medical groups go, we see ourselves as part of the solution. So with that, we must remain opposed, but again, are thankful for the author for removing the reference to RBOs.
Thank you, and I thank you for being concise and apologize for putting any time constraints. We do have 5 more bills, so we're going to have some further conversation, and members may want to invite you to respond to questions. How much time? Yeah, so 3 minutes for proponents if you choose to use those 3 minutes, because I did shut you down earlier.
Quite all right, thank you. Michelle Cabrera with SEIU again. I think part of what we're getting at here is that this is less about sort of how care is delivered. We didn't hear a lot about that in the opposition's testimony. We heard about markets, we heard about physician rates, et cetera. This is about monopolies in the industry and how those monopolies and the business practices around them have really gotten away from the regulatory and legal framework that's designed to help protect consumers and patients. And so there's an urgent need to fix this because these practices have impacts on the overall costs of healthcare. Individual costs are going up dramatically. Employer costs have been continued to go up. And we have evidence that these market monopolies are driving healthcare costs up without an equal value to the patients and the consumers. So we're not seeing that care coordination, that care integration at the healthcare system level or at the individual patient level in the ways that have been discussed. So we have, promises of that, but the reality just isn't there yet. And so I think there does have to be some alignment, obviously. We've got some work to do to get us there, but really this is about trying to figure out some solutions and to update the laws according to what we're seeing in the field. And so I'll leave my colleagues to the rest of the time. Thank you.
How much time? About another minute and a half.
Yes, I would just want to echo that this is really about disrupting the market when there's a monopoly market. And so we want to make sure that all of these things are in place to prevent any kind of provisions that hospitals can put in place, especially these dominant providers. I don't think we want to get into individual physicians. And just for an example with the tiering, when our plans do tiering, tier 1, they're going to put the high cost, low quality provider, and that means they're going to be a higher copay. In another tier, you're going to have a high quality, lower cost provider that will be a lower copay or will pay for all of the care. It's not physicians. We're talking about facilities, and this is a tool that we use to be able to make sure we can drive cost containment and drive quality improvement. So this is, I think, the intent of the bill, and hopefully these amendments are moving towards getting at those points.
Thank you. 30 seconds if you want to use it.
Just one final point is that, there are some mergers that are being reviewed by the state now. One example of merger activity that's not reviewed at all is vertical integration, where the plans, the hospitals, and physician groups integrate, align, consolidate, merge, whatever you want to call it. Those are flying under the regulatory radar right now. They have significant, pose a lot of significant concerns for consumers. They have potential to reduce costs and improve care coordination, but they're actually, it's very limited evidence that that actually happens, and we think that that needs to be reviewed and better understood and monitored going forward.
Thank you. Okay, so now we're going to ask add-ons in opposition. Any others want to add their voice to the opposition with a me too? Seeing none, I think the opponents are well represented. We have everyone up here at the table. I think before we open it to member questions, I'm going to ask the author if he wants to provide any response to what you've heard, and then we'll open it to questions.